Hello, everybody. Welcome to another episode of our Facebook Live. We are delighted to have with us today Dr. Brittany Banbury, who's one of our newest rheumatologists here in the Division of Rheumatology at Mount Sinai, Beth Israel, and on faculty at the Icahn School of Medicine. Thank you so much for joining us.
Thank you for having me.
It's really a pleasure because, we see every day in our primary care practices, we see all kinds of rheumatologic complaints and concerns, and I think probably nothing more commonly than arthritis. And so we really wanted to focus today, talking about sort of the different kinds of arthritis and how we can handle that and who needs a specialist, all those kinds of things. Can we just start with the very basics? I mean, I know that not all joint pain is arthritis, but start by just reminding us, what is arthritis and how do people know that when their joints hurt, if that joint pain is arthritis?
Okay, so arthritis is generally an umbrella term that we use to describe joint pain or joint disease. But as rheumatologists, we like to differentiate between something called arthralgia and arthritis. I'll explain a little bit more. In its true definition, arthritis means inflammation of the structures within a joint where two bones meet and kind of move against each other, like in your knee. These structures would be the two bones themselves that are moving against each other and the capsule that encloses those bones. And then there's also some fluid that is in that capsule, and it's made by the lining that we call the synovium. So when these are inflamed, there's typically warmth, redness, tenderness, and swelling of the joint that's affected. With arthralgia, however, there would be just pain around the joint without that warmth and redness and tenderness and swelling that we think of as doctors that are characteristic signs of inflammation. And if we think about it, there are a bunch of other structures that hold the joint together and help it to function, like tendons, ligaments
and stuff,
bursa, and those, along with the muscles that help to move the joint. And these can also become irritated and cause pain in the area around the joint, but this is technically not considered arthritis. That's where things like tendonitis and bursitis come into play. So folks can look for signs of inflammation associated with their joint pain, like the redness, swelling, warmth, and sometimes even stiffness, and also try to distinguish if the pain is within the joint itself, like between the two bones, or if it's in the soft tissue areas around the joint.
Got it. So people are looking like at their actual knuckles, trying to see if it's red, see if it's soft and squishy,
right,
and see if the pain and stuff is inside the knuckle or around the knuckle, I guess.
Exactly.
All right. Okay. And so then if it is arthritis, the kinds we hear about the most, I guess, are rheumatoid arthritis and osteoarthritis. So maybe we should narrow down and talk a little bit about those two first. How do you differentiate, and how do you think through that a little bit?
I think this is a great thing to talk about because often I'll ask my patients if anyone in their family has any kind of arthritis, and they tend to have a hard time differentiating or remembering if grandma had rheumatoid arthritis or osteoarthritis. So I think this is pretty important to clarify.
Yeah.
So arthritis is by far the most common, osteoarthritis is by far the most common type of arthritis, and it can affect any joint. But most frequently it's seen in the knees, the hips, and the spine. Interestingly, we used to think of it as more of a wear and tear condition where the cartilage within joints becomes damaged as a result of many years of use, more of like an inevitable disease of old age. But lately, research is actually showing that osteoarthritis is a disease of the entire joint, including cartilage, bones, and ligaments, and it is in fact driven by inflammation. Yes, and there are other factors that are associated with the development of osteoarthritis that's important, including trauma, like a torn ACL or recurrent dislocations or an old fracture, and also being overweight, having a poor diet, and a sedentary lifestyle. We haven't yet found any effective pharmacologic therapies for osteoarthritis, but unfortunately, we try to manage it more with pain medications, physical therapy, lifestyle medications, and like exercise and weight loss. So rheumatoid arthritis, on the other hand, is an autoimmune disorder, meaning a disorder where your body attacks its own tissues. It's also driven by chronic inflammation, but here the inflammation primarily affects the synovium. So we talked about that lining in the joint capsule that produces that fluid. And that's what your body is fighting against. And this will result in that painful swelling with the redness and the stiffness and the tenderness. And eventually, we'll see erosion of the bones and some irreversible deformities that often people will remember. Oh, yeah, grandma's hands, she couldn't use them after a while because they were so kind of almost claw-like. And that's mostly if the disease is untreated. But also, it's important to remember that in rheumatoid arthritis, the inflammation isn't only limited to the joints, but it can damage other parts of the body, like the eyes and the lungs. Unlike osteoarthritis, though, we do have a variety of pharmacologic treatment modalities that are effective in rheumatoid arthritis, not to cure it, but to bring it to remission and control inflammation.
Yeah, we're going to come back to all those treatment things in a couple of minutes. So,
Sure.
I'm ready for that. In the meantime, before we get too far afield, I did want to ask you about, there's some other kinds of arthritis or arthritis-like things that I often think about. Maybe we should just mention them so they stay in our heads while we're thinking through this.
Definitely. So there are actually over 100 different types of arthritis. Way too many to list in our short discussion today, but I'll try to name a few. So some of the other inflammatory arthritis conditions are things like psoriatic arthritis, axial spondyloarthritis, kind of a tongue twister there, and juvenile idiopathic arthritis can be seen in children. There can be also arthritis associated with infections from bacteria, viruses, tick-borne illnesses, sexually transmitted infections like gonorrhea and HIV. And also there are types of arthritis associated with metabolic conditions like gout and pseudogout. So that's a very limited, by no means exhausted list, but
that's good. Those are the things that I'm thinking about. Especially when people have pseudogout or something, and they're thinking they have some other kind of arthritis. It ends up being a meaningful discussion sometimes in our office. All right, so people have joint pain, they think it's arthritis. What should they think about? How quickly do they need to come see the doctor? Is seeing the primary care doctor okay? What kind of workup do we do next? And sort of how often, when do they need to go see the specialist, or what are sort of the triggers to figure out how to escalate the pathway?
So any kind of joint pain, I would say, that causes the patient concern or disrupts daily activities should be evaluated by a doctor. Generally, if it's lasting for 3 days or more, involving multiple joints at the same time, and or happening many times for the month, then it should be evaluated by a doctor. They can go through primary care initially, and we'll talk about some more investigations that a primary care doc can do. But things that they can look out for, aside from the pain, are, again, those signs of inflammation, the swelling and stiffness and redness. And then also think about if they're feeling unwell in association with their joint pain, like having a fever, a new rash, they're feeling more tired than usual, losing weight unintentionally, their hair is falling out more than usual. So those are the kinds of things. So fast forward to landing in their primary care doctor's office. Basic testing that the primary docs can do that can be helpful if you're suspecting inflammation include a complete blood count, which can show anemia of chronic disease or inflammation. Sometimes elevations in things like the platelets in inflammatory states, or in systemic autoimmune conditions, they can also be low. A metabolic panel looking at the liver and the kidney can show any evidence of end organ damage in association with a systemic autoimmune condition with arthritis. Then there are markers of inflammation like ESR and CRP, erythrocyte sedimentation rate, C-reactive protein. And these are non-specific. They can be elevated in multiple conditions, including infection, but it can also be useful to evaluate patients if you're suspecting an autoimmune, and it can kind of bolster your diagnosis if you're thinking there's joint pain and there's evidence of inflammation.
Right. So in some things, like in osteoarthritis, that would be normal mostly, right?
Correct. Yes. It can be useful to, again, evaluate for infection where relevant. So if you have sexually active patients, screening for sexually transmitted infections, patients who love to go hiking, just got back from Maine, Lyme disease, they spend a lot of time outdoors, you think about those. So generally, I would advise against sending an ANA outside of a really strong suspicion for a systemic inflammatory disease. This is one thing I would say leave up to the specialist, because in fact, it can be positive in up to 15% of healthy individuals and up to 25% of individuals with a relative with autoimmune disease. And it's frequently positive in people over 70 years of age. So sometimes I'll get like an 87-year-old patient in my office with a positive ANA, and she has no joint pain, but she wants to know why is this blood test positive. So it can cause a lot of...
Sometimes, our patients come in and they know that ANA is the test for lupus and other kinds of rheumatologic diseases. So they want that as part of their evaluation.
Fair.
Or they want Lyme titers.
Right.
Because their joints hurt. And so this is like a key point, of our time together is don't jump to that.
Right.
That's usually not going to help answer the question, I guess.
Right. And can also cause some anxiety and confusion if it's positive and they don't have any systemic illness.
Got
it. Yeah.
So so that's blood testing. What about like X-rays and MRIs? How do you decide who needs it like that and when?
So X-rays can be really useful in evaluation of joint pain. So I tend to send most, if not all, patients with joint pain for an X-ray of the affected joint and also the contralateral joint, so the joint that's actually normal. It's nice to compare. And you can use the X-ray to look for changes in the bones, the space between the bones that we consider the cartilage. And it can also help to guide the diagnosis, whether it is an osteoarthritis route or if we're thinking of something more inflammatory. It can even show if there's fluid accumulation around the joint that can be taken off for examination under the microscope. MRI is more often reserved for situations where the X-ray is really not giving us any kind of clues, but the patient is still in a lot of pain and there's still evidence of some kind of inflammation, whether it be on the blood tests or symptom-wise. And it can show us any evidence of soft tissue injury or any early bone, what we call edema or fluid collection that can point towards inflammation, or it can be helpful in sometimes detecting infection.
Got it. Okay. So patients called my office, they're waiting for an appointment with me. What kinds of things can they do to help them feel better if they think this is arthritis?
Okay, so they can try over-the-counter pain medications like Tylenol or Aleve, Motrin, Advil, and those last three are in that family that we call the non-steroidal anti-inflammatory drugs. These we have to be careful with because a lot of patients with arthritis actually are not allowed to take these medications for other comorbid conditions like heart disease or kidney disease, or in some even patients who have history of stomach ulcers. So that can be a little bit controversial. In that case, you can try them with like topical versions, gels to rub on the skin like Voltaren gel, which is a gel version of something like Motrin. And then there are other anti-irritant topicals, I should say, that are like capsaicin or Bengay, menthol creams. And these can help to improve pain while waiting. And then I like to think about whether or not movement is making the pain worse for the patient. If it makes the pain worse, I would generally advise them to rest the joint. If it makes the pain better, however, I would say they should continue to remain active.
And are there other non-pharmacologic things like that? What about like heat and ice and
so ice and heat therapy
kinds of things?
Yes, so ice and heat therapy can be very helpful for inflammation. We've also found that bracing of the affected joints can be helpful in limiting pain in patients with osteoarthritis or even an old injury. Low impact exercises like Pilates, yoga, Tai Chi, these can help to strengthen the muscles and balance, to improve joint mobility. I like to recommend swimming. It's a good form of exercise that doesn't put a lot of stress on the joints. Supplements are kind of controversial. We don't have a lot of evidence to prove their efficacy, to the point where we're not really recommending them. But if patients do come to me with improvement in their joint pain and they're on turmeric and or glucosamine chondroitin, then I don't offer these as part of I don't ask them to stop, but I don't generally offer them as my treatment modalities.
Right. I mean, there are certainly people who swear by both of those, I guess.
Definitely.
Turmeric, certainly, we have a lot of collaborators who rave about it as well.
Mm-hmm.
But I guess the evidence just isn't there yet.
Not yet.
And what about like vitamins, like vitamin D or anything? I mean, are those helpful at all?
I wouldn't say they're helpful in terms of joint pain. Really low vitamin D levels have been associated with kind of neuropsychiatric effects like low energy levels and depression. So I think if people are having associated fatigue, and they're feeling like, their energy is just not there and they're not able to exercise or go to work, then I would check their vitamin D levels and recommend replacing it. Women who are at risk for osteoporosis can benefit from calcium supplementation depending on what they're eating on a day-to-day basis. So those are the main things, but I wouldn't say necessarily joint pain would be affected there.
Got it. And what about, did we talk about physical therapy or occupational therapy? Like, how do those kinds of things fit in?
So they're always helpful. I think the physical therapists and occupational therapists, I don't think they get enough praise for the work that they do. They have so many different modalities to strengthen the joints, improve mobility. They can offer specialized bracing, and make kind of molded braces to different joints to help with supporting the joint that's injured. They can do things like paraffin wax treatment for hand osteoarthritis. And then in occupational therapy, I have a lot of my patients who come in who, they're really having a hard time moving their hands, but it's not necessarily inflammatory arthritis. It's more that they've kind of lost their muscle strength from longstanding osteoarthritis and lack of use. And so the occupational therapist can help with that fine motor exercise. So holding the pen or using the stress ball and things like that. So that can also be helpful in strengthening muscles and maintaining the health of the joint.
Got it. And then, as promised, we were going to circle back to the medication point of things. And for most of these, I think once we've gotten past the supplements, the NSAIDs, the Tylenols, the physical therapy, I mean, that's generally when I'm sending them to the specialist, to the rheumatologist, to sort of take a look and help direct the next round of therapy. So can you talk a little bit, I guess, for both osteo and rheumatoid, how do you think about medication treatment?
Right. So our first go-to, and people always say this about our consults and our recommendations, is that we tend to offer steroids. They are really good in the short term for stopping the inflammation. They provide pretty rapid relief of symptoms like swelling, redness, and pain. But long term, we tend not to keep patients on them because of.
When you're talking about steroids, you're talking about by mouth or injecting them into the joint?
Either one. That's actually a good question. I should clarify. So depending on how many joints are affected, I can very happily put a steroid into the joint rather than having a patient be taking a tablet long term. And that can, again, provide a lot of relief versus an oral medication or by mouth, a pill by mouth, where patients can take that for a couple of days and get some relief. But then we tend to add, if it's a systemic inflammatory process, we tend to add what we call DMARDs, disease-modifying anti-rheumatic drugs. We tend to add them at the same time as steroids because they take some time to take effect in terms of anti-inflammatory properties. So we continue both medications at the same time and then try to get the patients off of their steroids by mouth to prevent side effects and keep them on the DMARDs long-term to control the disease.
And what are some examples of DMARDs that you use?
So there are different kinds. There are the original conventional ones that we think about, like methotrexate. And then there are more recently ones that we called biologics that have been more popular in later years. And those are things like Humira or Taltz or etanercept or Enbrel. And these can be useful in a variety of different types of arthritis.
Yes, and I should highlight that we have a whole separate episode talking with one of our immunology colleagues about biologics for all kinds of different immunologic diseases. That's also in our Facebook Live series. So when patients come to see you, besides sort of finishing the workup, they might expect an injection of a steroid into a joint.
Mm-hmm.
Sometimes, I guess, depending on where the arthritis is, they might get injections of some other substances to try to help with their knee arthritis or something. And then potentially some of these disease-modifying agents to really decrease the development of the disease, the worsening of the disease over time. Both these sort of classic ones and really the new ones, the biologics, seem like they've made such a difference in rheumatoid arthritis over the last decade or so that they've been available.
They definitely have. Patients really have had improvement in their quality of life on these medications. But it's worth considering also that the side effects of these medications are quite varied. But overall, as an overarching theme, they are immunomodulatory medications, and so they do potentially increase risk for infection.
Right. And then the other lesson that I've heard over the last couple of years is to sort of think about, in particular, rheumatoid arthritis as something that's progressive. And so while the biologics and some of these other medicines can sort of stop or slow down the progression, they can't really reverse the changes. And so the secret for me, I think, as a primary care doc, and probably for a lot of the patients watching this, is the sooner you get treated for rheumatoid arthritis, the sooner you get it diagnosed and treated, the better it is. Does that sound like a fair takeaway?
Very fair. I would say that's accurate. And it's important to remind them as well that ongoing inflammation, which is the underlying driver of rheumatoid arthritis, increases their risk long-term for things like accelerated heart disease and also even malignancies in some cases. Yeah.
So come and see your rheumatologist early.
Yes.
Seems like it's the lesson of the day. Yeah. Dr. Banbury, thank you so much for joining us. I really appreciate it. Thanks everybody else for joining us. See you soon.
It's been a pleasure. Bye.